History and Physical presentation number 2 presents a 42-year-old African-American female with chronic respiratory failure and a chronic tracheostomy. She had recent AICD removal for an infection and treatment for a pulmonary embolus with Xarelto 15 milligrams daily. She presented to the ER from Kindred, which is a long-term acute care facility for bleeding from the tracheostomy site. She reported starting Xarelto a few days ago for a history of a PE. Her tracheostomy bleeding reportedly started yesterday morning. She was admitted to the floor for observation and initial lab workup. While on the floor, she had a coughing spell, which resulted in bleeding from her trach collar. She was transferred to the ICU, where her initial lab work demonstrated an INR of 1.1 and a slightly elevated PTT of 42. She continued to bleed around her trach with significant episodes of coughing. After 2 treatments of epinephrine, the hemoptysis failed to diminish, and her tracheostomy was then easily changed to a cuffed tube. She was placed on a ventilator and sedated with propofol. Her past medical history includes tracheal stenosis, hypertension, CHF, history of AICD, endocarditis, chronic respiratory failure, pulmonary fibrosis, lupus, diabetes mellitus, cardiomyopathy, and a chronic tracheostomy, which was placed December of 2013. Her current medications include Lasix, Bidil, potassium, Xarelto, aspirin, Coreg, Nexium, Plaquenil, and Losartan. Her review of systems I was unable to perform due to her current condition. Her physical exam. She was sedated and intubated. Her vitals were within defined limit or within normal limits, aside from her respiratory rate of 26 and her heart rate of 104. So she was slightly tachycardic and tachypnic. Her HEENT abnormality was the tracheostomy. Cardiovascular-wise was fine aside from tachycardia. She had no clubbing, cyanosis, or edema. There was a urinary catheter present, and cranial nerves, motor were intact, and no rashes on her skin. Her initial lab workup was fine aside from a decreased hemoglobin at 9.8, an elevated chloride level of 111, and an elevated BUN of 23. However, her creatinine was 0.93. Her PTT was also slightly elevated at 42. Her initial ABG prior to the tracheostomy change demonstrated metabolic acidosis, mixed metabolic acidosis, and respiratory acidosis. Her vent setting stayed the same after the change, and we repeated the ABG, which was essentially the same. PCO2 dropped slightly. Her initial PO2, I think, was mistakenly 335, but after the change it was 95.9. So she still was demonstrating metabolic acidosis and respiratory acidosis. Same vent settings, respiratory rate of 20, FiO2 of 100%, tidal volume 500, and PEEP of 7. So that was not changed. Her lab work the next day demonstrated the same decreased hemoglobin. This time we got a hematocrit level. They were both low. Platelet count was normal. Her CMP showed a remaining high chloride level, low carbon dioxide. The BUN decreased a little to 18. Creatinine was a little bit low at 0.59, barely. GFR was fine, greater than 60. Her glucose was 79. Her urinalysis showed protein present, as well as blood. So my differential diagnoses included: number 1, endocarditis or antiphospholipid antibody syndrome. Pertinent positives included hemoptysis, diffuse pulmonary hemorrhaging, seen on chest x-ray and bronchoscopy, a history of lupus, she had endocarditis, and she's female. Pertinent negatives included thrombocytopenia, as her platelets were normal. My second differential included a UTI, uremia, or renal tubular acidosis. Pertinent positives included a normal gap metabolic acidosis, diabetes mellitus, spontaneous bleeding, hyperchloremia, hyperphosphatemia, and her urine pH was greater than 60. An elevated urine pH in the face of acidemia is suggestive of renal tubular acidosis, which type 1 RTA can be caused by autoimmune disorders such as lupus. But her GFR is normal, so her pertinent negatives include hypokalemia, nephropathy with a GFR of greater than 60, and there was no uremic frost. My third differential includes pulmonary embolus. Pertinent positives include hemoptysis, cough, history of PE. Pertinent negatives, she did not have atrial fibrillation. Her tachycardia was very mild, 104. Tachypnea had decreased as well, but she did initially present at 24 breaths per minute. She was slightly febrile at 101, I think was the highest temperature we got from the Foley catheter reading. She denied pleuritic chest pain to the best of her ability. She had no dependent edema, no elevated JVD, and no hepatomegaly. My treatment plan includes, for endocarditis and antiphospholipid antibody syndrome, I suggested the following labs: ESR, CRP, ANA, anticardiolipin, and DRVVT, which is dilute Russell's Viper venom time. Blood cultures ×2, echocardiogram to assess for pericardial effusion, serial H&H Q12 hours to monitor bleeding, obtaining the records from her previous TEE, which showed vegetation growth on the tricuspid valve, which was performed from a local hospital. We requested records, and to restart the daptomycin that she had been receiving treatment for her endocarditis. For my treatment plan for the UTI uremia RTA workup includes an MRI of the kidneys to assess for renal artery stenosis, thrombosis, or aortic dissection, check a lactic acid level, which was actually pending. It just takes longer to get the results. I recommended starting Cipro IV for empiric UTI and obtaining a urine culture prior to starting the Cipro. For a PE workup, I recommended a D-dimer, a spiral CT, if the CT was unavailable, a pulmonary angiogram, or VQ scanning. I also recommended a duplex ultrasonography to assess for DVT. The consults included a hem-onc referral for bleeding, infectious disease for tricuspid valve endocarditis treatment and evaluation, and a pulmonary referral for respiratory failure, as well as ICU admission. The disposition is continue ICU admission for mechanical ventilation sedation, monitor H&H for possibility of transfusion, and to keep NPO. Thank you.